Hello everyone, welcome back to the channel. In today's video, we'll discuss one of the fastest evolving areas in infectious diseases, the newer antifungal agents and, more importantly, where they fit into today's management algorithm. For many years, our antifungal choices were limited to amphotericin B, fluconazole, voriconazole, and the echinocandins. However, increasing resistance among Candida, the emergence of Candida auris, azole-resistant aspergillus, and infections caused by difficult molds have led to the development of several newer antifungal agents. By the end of this video, you'll know which new antifungals are available, their spectrum of activity, advantages over older agents, clinical indications, and their place in the current treatment algorithm. Let's begin. Several challenges have emerged over the past decade. Increasing fluconazole resistance, multidrug-resistant Candida auris, azole-resistant Aspergillus fumigatus, toxicity associated with amphotericin B, drug interactions with triazoles, limited oral options for invasive fungal disease, and breakthrough fungal infections in immunocompromised patients. These problems have driven the development of safer and more effective antifungal therapies. Before discussing newer drugs, let's quickly review the traditional classes. Amphotericin B, azoles, for example, fluconazole, voriconazole, posaconazole, and isovuconazole. Candidins like caspofungin, micafungin, and anidulafungin. Now let's discuss the newer agents. Rezafungin is the first once-weekly echinocandin. Advantages: once-weekly intravenous dosing, long half-life of approximately 130 hours, excellent safety profile, and minimal drug interactions. Spectrum: excellent against Candida species, Candida auris, and Aspergillus species. Not active against Cryptococcus and Mucorales. Current indications include candidemia, invasive candidiasis, selected patients requiring prolonged outpatient intravenous therapy. Position in the algorithm: stable patient with candidemia requiring prolonged treatment after discharge. Rezafungin is an excellent option, reducing the need for daily intravenous therapy. Fosmanogepix is perhaps the most exciting antifungal in development. It inhibits GWT1 enzyme, which is involved in fungal cell wall protein maturation. This is a completely novel mechanism, meaning there is minimal cross-resistance with older antifungal classes. Excellent against Candida, Candida auris, Aspergillus, Pseudosporium, Fusarium, and some activity against rare molds. Available in both intravenous and oral formulation. Excellent tissue penetration. Potential option for multidrug-resistant Candida, Candida auris, difficult mold infections, and patients failing conventional therapy. Olorofim, the first orotamide. Another completely new antifungal class. Inhibits dihydroorotate dehydrogenase, blocking pyrimidine synthesis. Excellent activity against Aspergillus, Pseudosporium, and Lomentispora prolificans. Importantly, it has no activity against Candida. Clinical role: patients with azole-resistant Aspergillus, refractory invasive aspergillosis, and rare mold infections. This is likely to become a rescue therapy for difficult mold infections. Ibrexafungerp, the first oral triterpenoid. This is a unique oral antifungal. Like echinocandins, it inhibits glucan synthase, but binds at a different site. Unlike echinocandins, it is available orally, active against many echinocandin-resistant Candida, active against Candida auris. Clinical role: useful for vulvovaginal candidiasis, step-down therapy, resistant Candida infections, and outpatient management. Apoconazole, designed specifically for pulmonary fungal infections. Given as inhaled antifungal. Potential indications: lung transplant recipients, chronic pulmonary aspergillosis, and ICU patients with pulmonary aspergillus infection. Provides high lung concentrations with minimal systemic toxicity. Still under clinical development. Scenario 1. Patient with candidemia. Initiate: echinocandin. Blood cultures negative. Step down to fluconazole, if susceptible. If prolonged intravenous treatment is needed, Rezafungin may be preferred. Scenario 2. Candida auris infection. Initiate echinocandin. If failure or resistance, consider Fosmanogepix, where available through trials or future approval. Ibrexafungerp. Liposomal amphotericin B. Scenario 3. Invasive aspergillosis. First line: voriconazole, isobuconazole. The failure: liposomal amphotericin B. If failure, salvage therapy for refractory or resistant cases. Posaconazole, if the specific strain is susceptible, or Olorofim, once approved and available, may become an important rescue option. Scenario 4. Rare mold infections. Examples: Fusarium, Cedosporium, Lomentispora. Traditional antifungals often perform poorly. Emerging options include Fosmanogepix, Olorofim, liposomal amphotericin B, or combination therapy in selected patients. The future of antifungal therapy is moving toward novel mechanisms of action to overcome resistance, greater activity against Candida auris and resistant molds, oral options for prolonged therapy, long-acting agents that simplify outpatient management, precision therapy guided by fungal species, susceptibility testing, and host factors. Thank you for watching. If you found this video useful, please like, share, and subscribe to the channel. Also, let me know in the comments which topic you'd like to see next. Until next time, stay safe, keep learning, and practice evidence-based medicine.